respect him a great deal. We went 12 years without seeing each other. He went to Stanford and, sorry, man. And this terrible place called Ohio State that beat up on USC this year. But he's a well-trained guy. My chiropractor, Dr. Grant, was kind enough to give me his book, and I said, I don't like reading doctors' books. It upsets me most of the time. And then I saw it was him. I said, oh, now I got to see what this guy says. So I started looking at his podcast, which is called Boundless Health. I would highly recommend it. I use it all the time with my patients. It's an excellent resource. And he talked, because he's not just sold on this one concept. He's looking at veganism, this, to see how we give you the best health. His book is called The Best Health Ever, and it's really, I hate to say it in front of him, but it's really well done. Oh, and so I'm honored to have you here. And when I asked him to come speak, he's a busy guy. He has a lot going on. He's a busy cardiologist, and I kept him over, and I apologize. But he said, yeah, I'll be there. He didn't say, how much are you going to pay me? What do I get out of it? Can I advertise? And no, he said, I'll be there. I'll do it because it's important.
Wait,
so
you're
all
not
these
paying
guys.
Me?
No, you're not getting paid. Sorry to break it to you, man. Thank you. I might have to now. Oh, here's some water. There's a water right there for you.
Okay, thank you.
I'll take mine.
All right, so first, that's a tough act to follow, following Brian. So we got to reset our sensors here. So everybody stand up for a second. It's a health talk after all, so we got to stretch. All right, shake everything out a little bit. Reach up for the sky. Reach your head up high. Get their shoulder blades back. Suck that belly in. Maybe do a couple squats or something. All right, not going to lead an aerobics class, so that's good for now. All right, but as Brian mentioned, I'm a cardiologist. We trained together at Mercy Hospital for internal medicine residency. I then went on to Scripps Clinic and did a preventative cardiology fellowship, and then went into practice. And there's so much excitement when you get into practice. I was in the cath lab. I was helping people with blocked arteries. I was giving people statins and telling them to eat low-fat diets and really feeling like I'm going to make an impact here. And then it didn't take long to realize there was sort of this revolving door, and the same people are coming back again, and the same people. And when they're following your advice, when they're on the drugs, we weren't really solving the problem. And it kind of forced me to say, well, wait a second, what's going on here? I mean, I went into cardiology to really help people, and I didn't feel like I was doing that. And that's when I started to take a deeper dive, and that's when the whole concept of where our information came from and how we have been sort of led down the wrong path came. And Brian did a great job of explaining that, so I'll try not to get into that too much. But what he asked me to talk about today was the role of cholesterol. And because when we talk about eating fat, right away we think I'm going to die of heart disease, my cholesterol is going to go through the roof. And that's not just what sort of lay people think, the average person thinks. That's what your doctor is going to think too. And so I wanted to dispel a couple myths and talk about this today. So first, fats and lipids, what do they mean to me? Because for each and every one of us, it's going to be different, and that's part of the key. That's why my title says, what does it mean to me? And by me, I mean you, because it's not going to be the same for everybody, and here's going to be why. So first, when you talk about the benefits of a low-carb lifestyle, there are so many of them. You're going to improve your insulin sensitivity and glucose control, like Brian talked about. You can treat and reverse diabetes. You can reverse the metabolic syndrome. You're going to lose weight. You're going to improve your energy and decrease your hunger. So why wouldn't every doctor in the world want you doing these things? It's that fear. We're told that we shouldn't be eating fat because it's a fear that it's going to increase our cholesterol. And when we look at, so disclaimer, some of these slides might be a little hard to see. I apologize. I'll do my best to talk you through them. So the low-carb, high-fat diet versus the low-fat diet. What you can see, here are the keys. This is triglycerides on a low-carb diet. So much lower than a low-fat diet. HDL, so much higher compared to the low-fat diet. And here's the triglyceride to HDL ratio. So much better. And we're going to get back to this slide, but I wanted to plant this seed in your head to show you there's a significant difference in these markers on a low-carb diet. And so the concern is, like I mentioned, that eating more fat will increase your cholesterol and put you at higher risk. So if your doctor tells you that, the next question should be, well, why is that? What's your evidence behind that? And what do you know about the ratios and the difference of your cholesterol? And usually you get sort of a blank stare. And it's not necessarily the fault of your doctor because we're trained to follow guidelines. There's so much information out there in the medical world that the experts put together guidelines to make it much easier for us. So we know if we're following these guidelines, we're doing what's right. we're not trained to take a deeper dive into the information behind it. And that's where some of these people that Brian mentioned, like Ivor Cummins or Dave Feldman, they're engineers. They haven't been indoctrinated with these guidelines that we have. So they say, well, whoa, let's take a closer look at this. And let's find out why, and let's find out how this is made. And they're the ones who are helping revolutionize this. And that's what we need more doctors to know about. So you don't get that blank stare of just saying, well, this is what the guidelines say. We need to know more about it. So here is possibly one of the more important slides that I'm going to show tonight. These are all the published studies on the long-term impact of elevated lipids when you're following a low-carb lifestyle or if you have optimal insulin sensitivity. Okay, all the long-term studies showing the impact of elevated lipids or elevated cholesterol. There it is. All right. So I worked hard on this slide, okay? I did a lot of research. It took me a long time. It hasn't been studied. All the studies that are out there that have looked at the impact of cholesterol and lipids on your cardiovascular risk have all been done on either the low-fat diet or even worse, the standard American diet. This hasn't been studied. So you could say there are two ways to interpret the slide. Wait a second, it's a blank slide. How can there be two ways to interpret it? But there are. You could say, well, if it hasn't been studied, well, then maybe it is still dangerous and maybe I shouldn't follow it. Or you could say, well, if it hasn't been studied, maybe there's something there to say it would be different. Now, just because it hasn't been studied doesn't automatically make it better, right? The impact of cholesterol hasn't been studied on left-handed redheads born the second week in January. But there's no reason to think that'd be any different than right-handed blondes born the third week of January. There's no mechanism behind that. But with the low-carb, high-fat lifestyle, there is that mechanism. There are plenty of reasons to think that it would be different, and that's what I intend to show you today. So to skip to the take-homes, the impact of LDL is not the same for all individuals. That's why I titled this, What Does It Mean to Me? What does it mean to each individual? Because when you factor in your metabolic health, your HDL, your insulin sensitivity, even the size and density of your LDL, all that and inflammation as well is going to impact what the LDL means. The second take-home, though, is cardiovascular disease is not multifactorial. So we're talking about LDL because that's what is out there. That's what the message we're hearing. But LDL does not mean heart attacks. Heart attacks do not mean LDL. They're not one and the same. Cardiovascular disease is multifactorial. Insulin resistance, inflammation, oxidation, endothelial dysfunction. Something has to cause vascular damage before you can start to get cardiovascular disease. Having a high LDL does not by itself cause vascular damage. LDL is one small risk factor, but it's a small risk factor that we can treat with drugs and make drug companies lots of money and make everybody happy because you're getting a small benefit. It's not the only cause. So the second take-home is cardiovascular disease is multifactorial. So if LDL was the main cause of heart disease, you would expect when you look at a graph of the average LDL of people hospitalized for a heart attack, they would all be over here in the 200 range and the 180 range. Well, that's not what this graph looks like. In fact, the average LDL of people hospitalized for heart attacks is somewhere in this like 70 to 130 range and really in like the 80, 90, 100, 110 range. These are so-called normal LDL cholesterol levels, but this is what the majority of people having heart attacks have for their LDL. And this is not sort of archaic information. This is out there that anybody can find. People are just choosing not to look at it because this slide by itself is pretty clear that LDL is not the only problem here. Here's another study, a little complicated, but focus on this part right here. Okay, this is death going up this way, so you don't want to be up high, and this is cholesterol increasing this way. And look where the highest point is, on a low level of cholesterol. All right, this equates to about 100 milligrams per deciliter, and then it goes down as cholesterol goes higher, and then finally goes up a little bit here at the end. But it's not a straight line that you would expect if cholesterol was the issue. So this is similar to that study that Brian mentioned. It was studied in elderly folks, which were defined as over 60, and associating their cholesterol levels with their risk of death. And it's clearly not a one-issue problem here. All right, then you may have heard of the Framingham Study. This was one of the original studies that followed people for decades to see what is going to make them at risk for heart disease. And their conclusion was LDL is one of the big ones. Well, so was smoking and high blood pressure. But this is where a lot of the LDL hypothesis came from. And this is the data that, again, isn't hard to find, just people don't look at it. So here you have LDL of 100, LDL of 220. Okay, so this is LDL increasing. Here you have HDL of 85, HDL of 25, so HDL decreasing. So if you look at low LDL, high HDL, that would be this one right here, that's your lowest risk. If you look at high LDL and low HDL, that's your highest risk. Those make sense. But now look at this. Here's your low LDL with your low HDL. That's a pretty high risk with the low LDL. So if we look at the high LDL, it must be much higher, right? High LDL, high HDL, it's lower. So the LDL of 220 compared to the LDL of 100, your risk of heart disease is less than half when your HDL is higher. So again, it's not just the LDL. The LDL exists in your body. What's going on in your body is going to affect the characteristics of that LDL, and it's going to affect whether your body has the substrate that LDL can cause damage. So think of an infection, right? You get an infection, you get a bad pneumonia. Your white blood cells are going to skyrocket. So if you were looking down from outer space and you just said, look, everybody who has pneumonia and a bad infection has high white blood cells. Maybe the white blood cells are the problem. We should treat the white blood cells. Not the case. They're going in there for repair. Well, LDL has a reparative role. It's one of the roles of LDL. It's crucial for cell membranes. It's crucial for the neurons in our brains. It's crucial for our hormones and our fat-soluble vitamins like vitamin D. LDL has all these roles plus repairing vascular damage. So if you have vascular damage, the LDL may start rushing in to that vessel to help repair it. Well, the same way white blood cells can cause an abscess and can actually cause damage, it's sort of a reparative mechanism gone awry, the same can be true for the LDL. But only if you give it that substrate, only if you have that vascular damage and the LDL exists in a way where it can do damage. And that's where you have to start factoring in the HDL, the triglycerides, and your metabolic health. This one's a little confusing, sorry, I'll pass that. Okay, so now back to this slide. Well, what gives LDL a better environment? Lower triglycerides. Boom. Low-carb, high-fat diet has it. High HDL. Boom. Low-carb, high-fat diet has it. Triglycerides to HDL ratio. Boom. Low-carb, high-fat diet has it. The ApoB to ApoA1 is like a LDL to HDL ratio, basically, and that goes down because you have higher HDL, lower LDL. So these markers that change better with a low-carb diet are those same markers that tell us cholesterol is not so important. So, not having studies in, what did I say, redheaded, left-handed people the second week of January? I think that's what I said. I think that was, not having studies in those people doesn't tell us much. But not having long-term studies on the impact of a low-carb, high-fat diet does tell us something because we have all this evidence to tell us, well, yes, it should be different. Not only could it be different, but it absolutely should be different because we're improving the metabolic health of our body. Now, it's not all about cholesterol either. So here, just focus on this blue line here. This is your hemoglobin A1C as it increases from 4 up to 8, and this is your risk of a heart attack from this trial called EPIC. And as you can see right away, even as you get to 5, a little bit over 5, it's starting to increase. And then here at about 6.5, it skyrockets. So hemoglobin A1C is a clear predictor. And for those who don't know, hemoglobin A1C is basically a marker of your average blood sugar over the past 3 months. So higher blood sugar, higher cardiovascular risk. So LDL is not the only issue. Cholesterol is not the only issue. What about inflammation? Brian briefly mentioned the CRP. A high sensitivity CRP is a measurement of inflammation in our bodies. So looking at this slide over here, this is your cholesterol. Again, lower cholesterol here, less than 130. Higher here, greater than 160, and the dark line is with a higher inflammation. But here you go, low cholesterol, high inflammation, your risk is higher than high cholesterol and low inflammation. So not just cholesterol, not just blood sugar, also inflammation. We're starting to find more and more things that we need to worry about. So an LDL is not an LDL is not an LDL. I can't hammer that home enough. It's more or less associated with heart disease depending on what's going on in your body. Okay, but wait, doesn't lowering LDL save lives, right? We're told time and time again, we need to take our statins because lowering LDL saves lives. And that's partly true. In secondary prevention, so the definition of secondary prevention is someone who's had a heart attack, had a stroke, had a stent, had bypass surgery, they've got vascular disease, cardiovascular disease already. If we put those people on statins and we treat 83 of them for 5 years, we will save one life. So statins save lives, sort of. If we treat 39 people for 5 years, we'll prevent one heart attack. And this is not cherry-picking the data. This is data that's out there looking at all the studies. The way they get around this is the relative risk versus the absolute risk. So here's an example. Your chance of winning the lottery is, say, 1 in a million, right? So you can buy a ticket for $1. Well, I've got a deal for you. I'm going to increase your chance by 100% and sell you that ticket for $10. Deal? Who's with me? Who wants it? I've got it right here. Because now your chance is 2 in a million. But that's a 100% difference. So the drug companies promote their studies saying there's a 30% reduction in heart attacks. And that's true. When you look at the relative risk, it's a 30% reduction. And most of them show a 1% absolute reduction or somewhere along those lines. And that's where these numbers come from, that treating 83 people for 5 years saves one life. And that's for people who already have disease. So now let's talk about people who don't already have disease. That's primary prevention. Now we're treating 60 people for 5 years to save one heart attack with no difference in who lives or dies. And if you're a lower risk primary prevention, so people who have 0 risk factors for heart disease, you have to treat 217 for 5 years to save one heart attack with no difference in who lives or dies. So all of a sudden, you got to start to question why we're pushing statins so much and not talking about other things like different lifestyle interventions like the low-carb lifestyle. And we mentioned inflammation. Statins also lower inflammation. So this is where the LDL hypothesis really breaks down and runs into criticism, because if you're lowering inflammation and lowering the LDL, you can't say it's the LDL. So what else can you do to lower inflammation? Well, you can sleep better, you can manage your stress, you can move your body regularly, and you can get those carbohydrates and the sugar and the processed food out of your diet. And trust me, that feels better than taking a statin. Sure does. So again, all those studies on statins, all the statin studies were done on either a low-fat or a standard American diet. So there's even some information out there to suggest if you're on a healthier diet that the statins have even less effect than those that are out there, than those that I showed. Now, that's not to say LDL is completely unimportant and has no role or no association. This is a slide this is a study that recently came out that a lot of the people in favor of the LDL hypothesis have been putting all over social media. And what they did was they took people, primary prevention, no cardiovascular disease, they checked their blood for their cholesterol levels. Nobody's on any drugs either. This is just all natural. And then they did a carotid ultrasound to look at the thickness of their carotid wall, or they did a coronary calcium score, which are markers of subclinical atherosclerosis, meaning you've got some changes to suggest there's some atherosclerotic process, even though you haven't manifested the disease. Okay? What they found is people with low cholesterol here increasing this way. The red's where you want to be. The red is no evidence of disease. So there's a clear trend as the LDL goes up, the amount of people with no disease goes down. And this is gray is a little bit of disease, yellow is moderate disease, blue is a lot of disease. And that increases as LDL goes up. So taken at face value, this says, okay, this goes against everything I just said because clearly LDL is important. But here's the crazy part about this study that I think identifies sort of what's wrong with society and what's wrong with medicine in general. They define these normal subjects, low-risk normal subjects, as having a fasting blood sugar of 126 and a blood pressure of 140/90. Now, to put those numbers in perspective, that's defined as prediabetes and stage 1 hypertension. And that's their normal. That's what they're using as normal, which kind of baffles my mind. So to their credit, they said, okay, well, we're going to identify an optimal group. And these numbers started to look a little less associated, but still associated when you looked at the optimal group. The optimal group had a hemoglobin A1C of 5.7, which is still bordering insulin resistance. I mean, if they were measuring insulin levels like Brian was talking about, I'm sure they would still have elevated insulin levels. That is far from optimal. I mean, optimal is a blood pressure of 120/80, a hemoglobin A1C of 5 or less, a fasting blood sugar in the 80s, insulin levels down like 2 or 3 for fasting insulin levels. That was nowhere near what they had defined as optimal. So that's what's wrong with medical data, medical societies. It's not being studied in the right group of people. So LDL is not inherently bad. It has a vital role in our body, and hopefully I can impress that upon you. It transports energy. These lipoproteins that carry LDL transport energy to our bodies. They transport our hormones and our fat-soluble vitamins, and we need them to survive. Cardiovascular disease, multifactorial. Oxidation, inflammation, vascular injury. It's not all about your cholesterol. Metabolic health and inflammation directly impact the importance of your LDL. And those are things that can be controlled with lifestyle. We don't need drugs to control that. In fact, there's a drug that's being developed to reduce inflammation, and it only costs about $70,000 a year right now for people to do it. And it was going around on Twitter, and someone replied, "Gosh, if only there was something less expensive we can do to lower inflammation. What could that be? And it just sums it up so well. So if you're losing weight, decreasing inflammation, reversing your metabolic syndrome, increasing your HDL, decreasing your triglycerides, then LDL is not as dangerous. I think I've hammered that home pretty clearly. And how can you do all that? With a low-carb, high-fat diet, with exercising and moving your body regularly, with getting restorative sleep, with managing your stress, with being part of a strong community, all those things. So if you can do all this and show to your doctor, look, I can do this with lifestyle, there's no way that they should turn you away and say, nope, because your cholesterol is going to go up, you're going to die. It has to be part of the conversation. And that's part of my job, is to try and teach other doctors this, to at least make it part of the conversation. So what does it mean to me? What do fats and lipids mean to me? It depends, and that's what we need to talk about. So I wanted to throw these pictures. This is a coronary calcium score. These are your arteries here. The coronary arteries. This is your left main, the LAD, the circumflex, and they're supposed to be the same color as your tissue here. And this is just chock full of calcium. So a coronary calcium score, if a doctor is worried about your cholesterol, you could get a coronary calcium score. If yours looks like this, okay, cholesterol could be a problem. There are probably 100 other problems if your calcium score is this high, but cholesterol could be a problem. If your calcium score is this, clean as a whistle, you should never be worried about your cholesterol, because if your cholesterol is 300 and you look like this, it's not doing any damage to your arteries. So you can ask for this test. And the purpose of showing you this is I want you to be armed. I want you to be ready if you talk to your doctor, because don't stop with your LDL. Ask your doctor, what about my HDL, my triglycerides, my triglyceride to HDL ratio, my insulin, my hemoglobin A1C, my glucose tolerance, my CRP, my blood pressure, my metabolic health, my calcium score. There's so much more. And a lot of this has to do with how we discuss things with our doctor. Because if you show up and say, oh, no, I know what I'm doing, and you get in sort of an adversarial conflict with your doctor right away, you're going to have a problem. But if you sit down and say, well, listen, doctor, I've done a lot of research in this, and it seems like there are other things that impact it. What do you think about checking a calcium score? What do you think about checking my insulin resistance and checking insulin levels? And all of a sudden, you can be the teachers, because trust me, most doctors out there need you to teach them about this stuff, which seems backwards, but it's true, because we're sort of in our own world and following our guidelines. But you bring this up to them, and you can start to change things for the better, both for yourself and for the next patient who comes along. It's a coronary calcium score. It's a CT scan, takes about 20 seconds. It's not always covered by insurance, so that's the other problem we're fighting here, but it's only about $100, and it's a pretty low radiation study. You know, the CT scans that you get for a blood clot, is about what we call 5 millisieverts. The coronary calcium score is 1 millisievert, so it's 1/5 the radiation of those in general. So it's something you can definitely ask about. All right, so thank you very much. Hopefully that changed the way you see about cholesterol. Thank you. Did we lose Dr. Lenzkes?
And I know a lot of people, I'm not going to talk anymore. I'm not going to talk anymore, guys. Sorry we kept you a lot. That was my bad. I just want to make those points so we understand it because it's critical and we missed it last time. The rest of this talk is not going to be like us two guys talking medicine stuff. The rest is going to be practical stuff. People are going to say, hey, here's what I do. We're going to have 2 nutritionists talk. Jeff Kotterman, who's in the back here, who's outstanding, is going to talk about what he's doing, what kind of experience he's had. And I've seen some of the experience he's had with these bodybuilder guys who are just doing unbelievably well. He's lost 20 pounds. That guy doesn't have 20 pounds to lose on a high-fat diet that I had to beg him to go on, right? So the point is, there's a lot to learn. I hope the big points are the insulin resistance. Don't worry about the fat as much as that you're told. And I think just doing research on your own, learning, don't take our word for it.